Welcome to our comprehensive guide on suturing techniques, an essential skill in surgical and clinical practice. Whether you're a medical student, a dental professional, or simply curious about how wounds are closed, understanding the basics of suturing is crucial. In this video, we'll explore the most commonly used suture types, their unique advantages, and the step-by-step methods for each. We'll also highlight important considerations for wound healing and suture removal. Let's begin by looking at the foundational knots that make all these techniques possible. The surgeon's knot is a fundamental knot used in suturing to secure tissue and prevent slippage. It involves a double throw on the first knot, followed by a single throw in the opposite direction. This technique provides extra friction, making it especially useful when working with tissues under tension. Mastering the surgeon's knot is key to ensuring your sutures remain tight and secure throughout the healing process. Let's take a closer look at how this knot is tied and why it's preferred in many surgical scenarios. Another basic knot is the granny's knot. This knot is created by tying in one direction, then repeating in the same direction, and finally tying in the opposite direction to square and secure the knot. While it's less secure than the surgeon's knot, it's still useful in certain situations. The granny's knot is often used when a quick, temporary tie is needed, but it's important to ensure the final tie is squared for maximum security. Understanding the differences between these knots helps you choose the right one for each clinical scenario. The interrupted simple suture, also known as the sling suture, is the most commonly used technique for closing wounds. In this method, the suture is passed through both wound edges at equal depth and distance, typically 3 to 4 millimeters from the wound edge. Each stitch is tied off individually using a surgeon's knot, and the next suture is placed 8 millimeters apart. This approach allows for precise tension distribution and easy removal if infection or hematoma occurs. It's especially valued for its strength and adaptability to various wound types. Interrupted sutures offer several advantages. Each suture is independent, so if one loosens, the others remain secure. This technique allows for precise control over wound edge eversion and tension distribution. It's also adaptable. Additional sutures can be placed as needed. If infection or hematoma develops, removing a few stitches can help manage the complication without compromising the entire closure. These features make interrupted sutures a reliable choice for areas under stress or where wound healing may be unpredictable. The simple continuous suture, also known as the running suture, is a rapid technique for closing linear wounds. After placing an initial interrupted stitch, the needle is reinserted in a continuous fashion, passing perpendicular to the incision below and obliquely above. This method distributes tension evenly and provides a watertight closure. However, if the suture is cut at any point, the entire closure can become loose. It's ideal for long, straight wounds where speed and uniform tension are priorities. The continuous locking suture, or blanket suture, builds on the simple continuous technique by adding a locking step. After each pass, the suture is withdrawn through its own loop, creating a series of locked stitches. This prevents excessive tightening as the wound is closed and maintains even tension throughout. It's particularly useful for long edentulous areas, tuberosities, or retromolar regions. The locking feature also provides a more secure and watertight closure, reducing the risk of wound dehiscence. Mattress sutures come in two main types, horizontal and vertical. These techniques are used when tension-free closure is not possible, such as in areas with significant muscle pull, or when adapting tissue flaps tightly to underlying structures like bone grafts or dental implants. Mattress sutures resist muscle forces, evert wound edges, and bring large areas of tissue into close contact, promoting optimal healing. Let's explore the specific methods for horizontal and vertical mattress sutures. The horizontal mattress suture is performed by passing the needle from one edge of the incision to the other, then back again in a horizontal manner. The distance from the incision line and the depth of penetration are kept consistent, but the horizontal spacing on the same side may differ. This technique provides broad contact between wound margins and is excellent for averting skin edges in wounds under tension, such as after tooth extraction. Proper placement ensures strong closure and optimal healing. The vertical mattress suture is similar to the horizontal type, but differs in the depth of needle penetration. The suture passes at 2 levels, one deep for support and one superficial to draw the wound edges together. This technique maximizes eversion and minimizes dead space, making it ideal for deep wounds or areas where healing may be delayed. The vertical mattress suture is remembered by the sequence far, far, reverse, near, near, ensuring both deep and surface tissue approximation. The figure of 8 suture is particularly useful for closing extraction sockets or adapting the gingival papilla around teeth. The suture starts on the buccal surface, 3 to 4 millimeters from the papilla tip, to prevent tearing. The needle is inserted through the buccal and then the lingual flap, repeated at a horizontal distance, and both ends are tied. This technique provides secure closure and helps maintain tissue position during healing. Subcuticular sutures are used when cosmetic results are a priority. The needle is passed within the wound, through the lower dermal layer, and emerges through the subcutaneous tissue. Continuous short lateral stitches are taken beneath the skin's epithelial layer, with the suture ends emerging at each end of the incision. This technique holds skin edges closely together, resulting in minimal scarring and an aesthetically pleasing outcome. Proper suture removal is essential for preventing complications. The area is first cleaned with normal saline to reduce infection risk. Using sterile instruments, the suture is gently lifted above the skin surface. Scissors are then used to cut one loop close to the skin, minimizing the chance of dragging contaminated material into deeper tissues. The suture is then carefully pulled out, ensuring minimal trauma to the healing wound. The timing for suture removal varies depending on the location and tissue type. Skin sutures are usually removed after 7 to 10 days, while mucosal sutures are taken out between 5 and 7 days. For delicate areas like the eyelids and lips, removal is recommended after 3 to 5 days. Scalp sutures may remain for 7 to 12 days. Removing sutures at the appropriate time helps prevent complications such as abscess formation, scarring, or stitch marks. Leaving sutures in place for too long can lead to several complications. These include the formation of sutural abscesses, increased risk of scarring or visible stitch marks, and even the development of implanted dermoid cysts. Monitoring the wound and removing sutures at the recommended time is essential for optimal healing and cosmetic outcomes. Always follow clinical guidelines and patient-specific factors when planning suture removal. Let's visualize the interrupted simple suture. Each stitch is placed at equal depth and distance from the wound edge, typically 3 to 4 millimeters away, and tied individually. The next suture is placed about 8 millimeters apart, ensuring even tension distribution. This schematic highlights the independence of each stitch, allowing for selective removal if needed. The technique is straightforward yet highly effective for most wound closures. Now, let's look at the simple continuous suture. After an initial interrupted stitch, the needle is reinserted in a continuous fashion along the wound. The suture passes perpendicular below the incision and obliquely above, creating a running pattern. The closure is rapid and tension is distributed evenly, but if the suture is cut at any point, the entire closure may loosen. This schematic demonstrates the continuous path and the final knot securing the suture. The continuous locking suture schematic shows how each stitch is locked by passing the suture through its own loop. This creates a series of interlinked stitches that maintain even tension and prevent over-tightening. The locking mechanism is especially useful for long wounds and ensures a watertight closure. The schematic highlights the loop and locking action at each step along the wound. The horizontal mattress suture schematic illustrates the needle passing horizontally across the wound, first from one edge to the other, then back again. The entry and exit points are consistent in depth, but may vary in horizontal spacing. This technique provides broad contact and is ideal for wounds under tension. The schematic shows the suture path and the resulting eversion of wound edges. The vertical mattress suture schematic demonstrates the two-level penetration, deep and superficial. The suture enters far from the wound edge, passes deeply across, then returns near the edge at a more superficial level. This maximizes eversion and minimizes dead space. The schematic clearly shows the far and near sequence, with labels for each penetration point. The subcuticular suture schematic shows the needle passing within the wound, just below the skin's surface, in a continuous lateral fashion. The suture emerges at each end of the incision, holding the skin edges closely together for a cosmetic result. This technique is ideal for minimizing visible scarring and is commonly used in areas where appearance is important.